Hi, this is Melinda Eshelman. I am a cardiac anesthesiologist at the University of Kentucky, and today I will be reviewing airway anatomy and the difficult airway algorithm. So first, airway anatomy. The airway is composed of both nasal and oral cavities, as well as the pharynx, the larynx, the trachea, and principal bronchi. So the oroesophageal and nasotracheal passages share space in the oropharynx, and as such, our body has evolved in order to protect the sublaryngeal airway and to make sure that our stomach contents and food does not end up in the trachea and stays in the esophagus or in the oropharyngeal area. So there shouldn't be any stomach contents or any food that passes below the level of the larynx or below the level of the vocal cords. The larynx is bordered anteriorly by the thyroid cartilage. The thyroid cartilage is a shield-shaped cartilage that protects the vocal cords anteriorly. Then the posterior border of the larynx is the arytenoid cartilage. So the larynx is located between the thyroid cartilage anteriorly and the arytenoid cartilage posteriorly. As far as motor innervation to the larynx, all motor innervation to the larynx comes from branches of the vagus nerve. There are two branches that supply motor innervation to the larynx. The recurrent laryngeal nerve supplies motor innervation to all of the intrinsic muscles of the larynx except for the cricothyroid. So every single muscle that allows your vocal cords to move is supplied by the recurrent laryngeal nerve except for that cricothyroid muscle. That cricothyroid muscle is supplied motor innervation comes from the superior laryngeal nerve. So the superior laryngeal nerve provides motor innervation to the cricothyroid, and then the recurrent laryngeal nerve is going to provide motor innervation to all other muscles of the larynx. One thing that we worry about with certain surgical procedures, particularly thyroid surgery, is damage to those recurrent laryngeal nerve. If you have damage to that recurrent laryngeal nerve, it will result in in vocal cord dysfunction, and your vocal cord will not be able to abduct as easily, and so it will be located more midline. And so if you have unilateral vocal cord paralysis, that can be okay, and usually there's no complications from that. But if you have damage to both of those recurrent laryngeal nerves, then both of your vocal cords are stuck more midline, and you can have stridor and difficulty breathing because of damage to those recurrent laryngeal nerves. A little bit more airway anatomy. The cricothyroid membrane is an important membrane, and actually, according to the ASA difficult airway guideline, each and every patient should be evaluated for a possible surgical airway, and that surgical airway will occur through the cricothyroid membrane. And a surprisingly few number of anesthesiologists were able to accurately identify the cricothyroid membrane. So the cricothyroid membrane is in between the thyroid cartilage and the cricoid cartilage, as it is aptly named. It is about 8 to 12 millimeters in width and about 10.3 to 13.7 millimeters in height, so it's not that big. When you are accessing or puncturing or making an incision on the cricothyroid membrane, due to variation in the course of veins and arteries, it's recommended that you make these needle punctures or incisions in the inferior third of the cricothyroid membrane. And again, it's recommended that we evaluate each and every patient and locate the cricothyroid membrane in case of an airway emergency. So the cricoid cartilage is just inferior to the cricothyroid membrane. It's about 1 centimeter in height anteriorly, and it's a little bit wider in the back. It's actually 2 centimeters in height posteriorly. So it's wider in the back than it is in the front, and it's a circumferential cartilage. And the trachea is suspended from this cricoid cartilage through various ligaments. The trachea itself in adults is about 15 centimeters. In pediatrics, the size varies based on age. And since I'm not a pediatric anesthesiologist, I will not pretend to be an expert on pediatric anatomy. But the trachea is about 15 centimeters in adults. And then there's about 17 to 18 C-shaped cartilages versus the cricoid cartilage, which is circumferential. These tracheal rings are C-shaped, and so the anterior part is cartilaginous, and then the posterior part of the trachea, there are no rings. So it's membranous posteriorly, and this is where it overlays the esophagus. Anatomically, the first tracheal ring is located anterior to the 6th cervical vertebrae. And then the carina is located at around the 5th thoracic vertebrae. So the trachea extends about from the 6th cervical vertebrae down to the 5th thoracic vertebrae, where the trachea bifurcates into the left and right principal bronchi. Now, the right principal bronchus is larger in diameter than the left principal bronchus. It has that take off a little bit earlier than on the left side. That right upper lobe takes off pretty early off of that right principal bronchus. And then the angle at which it deviates from the trachea is a little bit lower of an angle. Again, this is in adults. I believe it's different in pediatrics, but again, I'm not a pediatric anesthesiologist. So the right principal bronchus is larger in diameter and takes off at a smaller angle or a less acute angle. So what this all means is that if you aspirate anything, it has a tendency to go down the right side of the lung instead of the left side. Certainly it's possible that it goes down the left, but for the most part, it tends to go down the right side. Same thing with our endotracheal tube. If you've advanced your endotracheal tube too far and you've ended up endobronchial, it tends to be on the right side, not the left side. These cartilaginous rings that started at the cricoid cartilage, continued through the trachea, actually continue and support the first 7 generations of the bronchi. So there's a fair amount of cartilaginous support within the lungs and within the trachea and the first 7 generations of bronchi. Okay, now on to the difficult airway algorithm. So difficult and or failed airway management accounts for 2.3% of anesthetic deaths in the United States. And according to the ASA closed claim projects, which keeps track of this type of thing, it's the second most common cause of claims. And the ASA defines a difficult airway as difficulty with intubation, mask ventilation, or both. I think a lot of times we think a difficult airway is only difficulty with intubation, but it actually includes difficulty with mask ventilation or both. Because hypoxic brain injury can occur within a few minutes, development of an airway emergency increases the odds of death and or brain damage by 15-fold. So just the fact that you have an airway emergency significantly increases your odds of death and brain damage. Because of the morbidity and mortality associated with difficult airways and or failed airways, the ASA developed a difficult airway algorithm in 1993. This has been updated in 2003 and 2013. The most recent update in 2013 focused on the LMA and implementing it sooner instead of later within the algorithm. And I think we'll go through the algorithm in the next few slides, but the algorithm actually starts before you even start attempting the airway. The algorithm starts with evaluation of airway and development of a plan. So this isn't something that you should use only when you get into trouble. It's something that you should think about beforehand to avoid getting into the situation where you have a can't intubate, can't ventilate. So this is the practice guideline for management of the difficult airway, and this was published in 2013 in Anesthesiology, and I know it is small on this screen, and so I will link it below so that you can see it, but we're also going to go through this each step at a time. And again, the start of the difficult airway algorithm starts with assessment of the likelihood that you're going to have a problem with the airway. So it's not when you get into trouble, it's before you get into trouble. This initially wasn't part of the difficult airway algorithm, but it is now incorporated into the difficult airway algorithm. This was published in 2003 in the Journal of Clinical Anesthesia by William Rosenblatt, and it's the Airway Approach algorithm. So it's a decision tree for organizing preoperative airway information. So again, this is now incorporated in the difficult airway algorithm before you get to the algorithm itself. And so there's this decision tree that basically asks 5 questions. The first question is, do you need to control the airway? Is it possible to use regional, interaxial, or local infiltration of anesthetic instead? Is that a possibility? Regardless of if you think it's possible to do this procedure via one of these other means of anesthesia, you should still have a plan for airway control. So regardless of which anesthetic technique you choose, there should always be a backup plan for airway control. So the first question is, do you have to manage the airway? The second question is it possible that tracheal intubation might be difficult? So if there's no indication that tracheal intubation is going to be difficult, you can proceed. But if there are indications that tracheal intubation might be difficult, you need to be prepared. So even if you're not planning on accessing the airway, you need to be prepared. Do you need other resources, other rescue maneuvers? Make sure you have the necessary resources if you do run into problems. The third question is, can supralaryngeal ventilation be used? So can you use an LMA, basically? And if they have a small mouth opening, or you don't think you're going to be able to get an LMA in, or you don't think you're going to be able to mask in some way, you need to consider this when planning for your airway. The next question is there an aspiration risk? So if there is a risk for aspiration, then this patient is not going to be a candidate for elective supraglottic airway use. The next question on this airway approach algorithm is, will the patient tolerate an apneic period? So if you do have difficulty establishing an airway and you're unable to use a supraglottic airway, is it possible that this patient will tolerate an apneic period? So if you fail intubation and you are unable to ventilate via a supraglottic airway, or because you have difficulty or because it's unsafe, is this patient going to rapidly desaturate? And there are several things that contribute to this: age, pregnancy, pulmonary status, choice of induction agents. All of these go into whether or not a patient can tolerate an apneic period. And then the final question, which isn't really on here, but it goes with will the patient tolerate an apneic period? Can this hypoxia, if it develops, be rapidly corrected through other means? For example, is it possible to establish a percutaneous emergency airway? In many patients, this is possible. Obviously, it's not the ideal choice, but if your patient is morbidly obese or has scarring or has had radiation changes over the larynx and trachea, this option might not even be available. And so if that's the case, you need to consider that again before you get into trouble. So the previous slide kind of went through a decision tree in how to plan your anesthetic, and then to think about some of the problems that you might have as you're trying to establish an airway. The difficult airway algorithm starts with looking at your patient and assessing your patient and thinking about each of the different ways of establishing an airway and how or why they might be problematic in this patient. So if you decide to do an awake intubation, is there going to be difficulty with patient cooperation or consent? Is this a pediatric patient? Are they developmentally delayed? Is there a language barrier? All of these things can make establishing an airway while the patient is awake more difficult. So going to be difficulty with mask ventilation. Does this patient have really bad sleep apnea, large tonsils, a thick neck, an anterior mediastinal mass, something that you think is going to make mask ventilation difficult? Is placement of supraglottic airway going to be difficult? Is laryngoscopy going to be difficult? Is intubation going to be difficult? And then finally, the last step is surgical airway access. Is that going to be difficult? Again, we don't really want to get to this step, but it's better to think about it beforehand than to get to this step and realize that you can't establish a surgical airway. This next step might also sound somewhat intuitive, but as you are trying to establish an airway and as you are going through the process, you should be actively delivering supplemental oxygen to the patient. So in addition to trying to establish an airway, you should continue to deliver oxygen to this patient throughout this management of this difficult airway. And then consider the relative merits and feasibility of the basic management choices. We talked about this a little bit, but awake intubation versus a sleep intubation. If you have to do a fiber optic intubation, is it safe and feasible to do it asleep, or does it have to be done awake? Do you need an invasive technique, or can you use a non-invasive technique for the initial approach to intubation? Do you need to start with video-assisted laryngoscopy, or is it going to be safe to use and feasible to use direct laryngoscopy start? And again, is this patient going to desaturate quickly? So will you have time to get a video assisted laryngoscopy? What resources do you have available at your center? Is it possible to start the case with video assisted laryngoscopy present in the room, or is it going to take a few minutes? Preservation versus ablation of spontaneous ventilation. Is this a patient that that you should maintain spontaneous ventilation throughout induction, or is this a patient that's going to be okay once you relax and make it so that the patient is no longer breathing spontaneously? All of these things, again, should be considered before induction as you're assessing the patient. And then finally, develop primary and alternative strategies. And this is where the familiar graphic comes in. So the first part of the difficult airway algorithm is on the top left of this screen. And it's when you've evaluated your patient and decided that it is unsafe to attempt an asleep intubation. So you've decided to do an awake intubation. So you attempt a non-invasive intubation, and then if you succeed, wonderful, you can put the patient to sleep and then continue with your case. If you are unable to secure the airway while the patient is awake via non-invasive mechanisms, your choices at that point are to either cancel the case, consider the feasibility of other options, or decide to go to invasive airway access. This is when we start thinking about perhaps doing an awake trach. You would want other services present in order to help with that. But if you're unable to get the airway while the patient's awake, cancel the case, consider other options, or consider if an invasive airway is going to be needed. Now, this next part is where the difficult airway algorithm, really, we hope to not get to this point, but must know the algorithm. So we've evaluated our patient, assessed the airway, and decided that it is safe to attempt placement of an endotracheal tube after induction of general anesthesia. So what we hope happens is on the left that you induce and then you're able to successfully establish an airway. If you are unable to establish an airway, you have a couple things that you should consider right away. One, calling for help. Two, try and return to spontaneous ventilation. So if you've used sucks, you have to wait for the sucks to wear off. If you use rock, consider reversal, and then awake the patient. And then we advance to the next part of this algorithm. So at this point, you have an asleep patient and initial attempts at intubation have been unsuccessful. In anesthesia, I like to say that we hope for the best, but plan for the worst. It is our job to be prepared for the worst. And so we hope that we can go down the left side of this pathway and we are able to face mask ventilate this patient and that this ventilation is adequate. If we are able to mask the patient and mask ventilation is adequate, we have time to figure out what to do next. We have time to gather resources, time to figure out, do we need to wake this patient up? What is the next step that needs to happen? Things to consider if you're unable to intubate, using a fiber optic, using a bougie, a stylet of some sort, a retrograde wire. These are all possibilities if you're unable to get an airway by traditional means. Hopefully, you're able to use one of these mechanisms and have a successful intubation. If you're unable to have a successful intubation, again, consider some of these invasive airways, access, or wake the patient up. On this side, since you're able to mask ventilate, you have a little bit more time to figure out this decision. If you're unable to mask ventilate, that's when we really start to worry. This got moved up from the 2003 to the 2013 iteration of the difficult airway algorithm. So if you're unable to mask a patient, you pretty much immediately go to a supraglottic airway or attempt a supraglottic airway. And hopefully, again, we're able to get some sort of LMA in and able to ventilate the patient this way. And then we can start considering what's the best way going forward. Are we going to use an intubating LMA? Are we going to, what other tools are we going to use in order to establish this airway? If we are unable to establish a supraglottic airway, this is when you start going down the emergency pathway, and we really do not want to get there, but we should be prepared if we need to get there. This emergency pathway is when you are unable to establish adequate ventilation and you are unable to successfully intubate. At this point, you should definitely call for help. Perhaps at some point you've called for help or additional supplies earlier, but call for help and establish emergency non-invasive airway ventilation. Again, bougie, using some other tools in order to establish an airway. And if all of these fail, you really need to consider quickly emergency invasive airway access. Now, you don't want to consider this before you've tried some of the other means of establishing an airway, but again, 2.3% of anesthetic deaths are due to an inability to establish an airway. And so we really want to avoid getting there. So we have to be ready to establish invasive airway access, whether this is a retrograde intubation, whether it's a cric of some sort. We need to have a plan for what we're going to do if we get to this stage. We don't always have time to wait for our ENT colleagues. Ideally, they could be present and help us with this, but if you run into an unanticipated difficult airway and you're unable to mask this patient, we need to have the tools and skills to establish an invasive airway access. Thank you all for listening. This presentation, I won't lie, even as I'm talking about the difficulty of establishing an airway, sometimes it makes me a little bit anxious because I would rather never do a cric in my career, but it's important to be able to go down that algorithm and to know that algorithm and to remain calm during these scenarios. These were my references that I used. I will make sure that the practice guideline is linked below, and then I used Barish, and then again that Rosenblatt article about the Airway Approach algorithm, where you first start thinking, it starts with step number 1. Do I even need an airway? Thanks everyone, and I hope you learned something.